Now the final in the hemolytic anemias is on immune hemolytic anemias. The characteristic feature of the immune hemolytic anemias is your direct COMS test is going to be positive. That is straightforward, typical. That is the one thing that you have to know about immune hemolytic anemias, or simply you can call it as autoimmune hemolytic anemias as well. So there's another name for that. So before going to the details on what is warm or what is cold or what is paroxysmal cold, let us have some look on what really autoimmune hemolytic anemia causes. The main problem in the autoimmune hemolytic anemia is the formation of this immunoglobulins. That is nothing but the antibody formation. Again, certain components of the red cell membrane or something against the red cell. That's it. So these immunoglobulins, once they are bound to the red cell, they're going to cause a variety of problems because these immunoglobulins are very good opsonizers. So which we'll discuss later on. So they're very good opsonizers. So once they opsonize, this will be recognized by because these have the FC fragment, isn't it? So this FC fragment will be recognized by the macrophage FC receptors. They have FC receptors which recognize this attached immunoglobulin, and they are going to damage the RBC, resulting in spherocytes, and then will result in extravascular hemolysis. Or this antibody directly can destroy the RBC, resulting in extravascular hemolysis. So number one, so you are going to result in extravascular hemolysis. And second thing, what is going to happen is complement activation. You know very well, in this condition, the RBC acts as an antigen, some antigen on the RBC, and you have an antibody. So which means you are forming an antigen-antibody complex here. So the moment you form an antigen-antibody complex, you are going to activate the classical complement pathway. The classical complement pathway will be activated, which means your C1QRS will be activated, apart from that C4, C2, C3, which is a common pathway. Then again, once C3 is activated, you are going to result in the formation of C3b, which you saw in the last video itself, which will further result in the formation of C5. So C3 will activate the formation of C5. C5 will further form this membrane complex MAC, and they are going to result in intravascular hemolysis because of formation of pores in the target. And similarly, the C3b is also a very good opsonizer. We discussed already. The C3b is going to opsonize, and again, this opsonization means this will be recognized by macrophage complement receptors, and they are going to go for extravascular hemolysis as well. So that's what is going to happen. So which means whenever you have an autoimmune hemolytic anemia, the primary problem is the antibody. That's the primary issue. This antibody is a primary problem. So once you form this antibody is going to cause hemolysis. This hemolysis can be extravascular or intravascular. Certain autoimmune hemolytic anemias can cause intravascular hemolysis predominantly. Certain autoimmune hemolytic anemias can cause extravascular hemolysis predominantly, but many of the times it will be mixed. They can have both intravascular as well as extravascular hemolysis. That's why I am writing plus or minus. And in between, you might result in additional complement activation also. Additional complement activation also in between. So the main problem is the antibody formation, and that antibody is the main reason why you get this direct COMS test positive. So because it's an autoimmune mechanism, that's why your direct COMS test is positive. So now you know very well. So these are the pathophysiology of why you are going to get a autoimmune hemolytic anemia. This is the overall pathophysiology that we are going to discuss. But there are three types of autoimmune hemolytic anemia. In that you can actually broadly classify into two. Then you can, including subdivisions, you have three. The two broad classifications will be, one is called a warm autoimmune hemolytic anemia, number one. Second one, you have something called a cold autoimmune hemolytic anemia. This is number two. In this itself, cold autoimmune hemolytic anemia, you have two types of cold autoimmune hemolytic anemia. That is called cold agglutinin disease, or otherwise called as cold agglutinin syndrome. And second one, you have something called a paroxysmal cold hemoglobinuria. It's called PCH. It's not a PNH, it's a PCH. That's called paroxysmal cold hemoglobinuria. So these are the major divisions, to be honest. Cold I can put in blue. So these are the major divisions. And you have a warm autoimmune hemolytic anemia as well. So what will be the features? Feature number one, if you ask me, incidence wise, if you ask me, almost 70% of the hemolytic anemias, autoimmune hemolytic anemias, tends to be warm. Only 15% tends to be cold, and only 1 to 2% tends to be paroxysmal cold hemoglobinuria. Remember, there are certain mixed also. There can be warm and cold may coexist together. This is called mixed autoimmune hemolytic anemia. That's quite rare, and again incidence is approximately 5 to 10% only. But in exam this is not at all important, not that much needed. But what is more important is these three things: this warm hemolytic anemia and cold, which is cold is further subdivided into cold agglutinin, paroxysmal cold hemoglobinuria. And second one, if you ask me what is the antibody type is typically IgG, and here it is typically IgM, and again in paroxysmal cold hemoglobinuria typically it is IgG. What will happen in these conditions, whether they can activate complement or not? Remember, IgG is a poor complement activator but an excellent opsonizer, we know that, but it's not that good complement activator compared to IgM. So since complement activation is actually poor with IgG, so typically you will result in no complement activation. Usually complement is not activated. But whereas if you ask me IgM is an excellent complement activator. IgM is an excellent complement activator, so that is the reason you will have complement activation here. So if you ask me here also, even though it is IgG, here there will be a decent amount of complement activation because of the mechanism that is happening, which I will tell you in some time. What is the mechanism that is happening? If you understand that, you might think it's easy. So it, to an extent, it can activate the complements as well. Then number 4, you have something called when will the antibodies will bind? Antibody attachment. So when the antibodies will attach with the RBCs. So usually the name suggests it's warm. So usually the antibody attaches at 37 degrees Celsius. That is a normal body temperature. That's a warm temperature. This is the time where the antibody attaches optimally with the antigen, target antigen in the RBC. But here it actually attaches at less than 37 degrees C optimally, which means they don't attach properly at normal warm body warmth. Actually, when the temperature is less, they attach with the RBC. So which means typically maximum attachment will be at 0 to 5 degrees C, but anything less than 37 degrees C, they attach much better. The more you reduce the temperature, more they are going to attach with the target antigen, that is the RBC. But here the most important thing that is that the antigen has a biphasic nature. Biphasic nature means if you cool the RBCs to 0 degrees C, it doesn't attach. If you warm the RBC to 37 degrees C, they don't attach. So you have to have something called biphasic nature, which means the antibody will optimally attach. First, if you initially cool to 4 degrees C, then you again warm the RBC back to 37 degrees C. So then only they will optimally attach. So it's not like just putting in cold, antibody will not attach, and just putting in warmth, antibody will not attach. You have to initially cool, then you have to rewarm them again. So this biphasic nature, initial cooling followed by rewarming, is the thing that optimally attaches the antibody with the target cell, that is RBC. So that's what is going to happen. Number 5, what is antigen? Which means you have an antibody, means you have an antigen on the RBC membrane. So what is antigen? Antigen in autoimmune, warm type is Rh antigen and band 3. So these are the usual antigens, whereas antigens in cold agglutinin disease will be your I antigen. I antigen will result in formation of something called anti-I antibody. Whenever I read capital I, anti-I antibody, typically this anti-I antibody is seen in mycoplasma infections. Next you can have small I antigen. This is called anti-small I antibody. Typically this is seen in infectious mononucleosis. Both are exam questions. Rarely you might get with PR antigen also. PR is also RBC surface antigen, so we might get with PR antigen also. This is what is referred to as something called cold agglutinins, for example. So these antibodies are what we refer to as something called cold agglutinins. So these are the antigen, target antigen against which antibodies are formed. So here the antibody is called something called Donath antigen. Antibody is called, actually this biphasic antibody that is found in this paroxysmal cold hemoglobinuria is what we refer to as something called a Donath-Landsteiner antibody. Donath-Landsteiner antibody. Here the antigen is actually the P antigen. Antigen is actually the P antigen, otherwise referred to as Donath-Landsteiner antigen, but here typically we call it as a P antigen against which antibodies are formed. Those are called as Donath-Landsteiner antibody. So you have antigen, then you have testing. Testing wise, if you ask me, it is IgG plus or minus, if you do a DCT direct Coombs test, it will show usually IgG plus or minus C3, which means IgG alone will be seen in 70% of the cases, and C3 alone will be seen in 10% of the cases, and IgG plus C3 will be seen in approximately 20% of the cases, which means very often you will find IgG alone in the direct Coombs test. That's what you're going to find out. So this is the resultant DCT. Typically the maximum hemolysis will happen at 37 degrees C. Optimal hemolysis or maximum hemolysis will happen at 37 degrees Celsius only. So here if you do DCT, typically it will be positive for C3 only, and the test will be optimally positive at less than 37 degrees C, will not be positive at normal body temperature. Here if you do a DCT, remember at 0 degrees C, if you see test will be negative. At 37 degrees C, if you perform again, the test will be negative only. There will be no doubt about that. Remember, initially you have to cool down to 0 degrees C, then you have to rewarm at 37 degrees C. In this condition, the test will be positive. DCT will be positive and it will show C3 only. DCT will be positive and it will show C3 only. Here, even though the antibody is IgG, they activate the complement. That is because of the biphasic nature of the antibody. I am not telling IgG is not going to activate complement, but it's a very poor activator of the complement. But Ig can activate complement a little bit much better when in colder conditions compared to warm conditions. That is the reason why in donut lancet antibody, even though it's an IgG, it's going to activate the complement definitely. So you will see only C3 and it's actually a complement mediated lysis only. It means what you can see is the cold types are actually complement mediated and the warm types are not actually complement mediated. So this is what is going to happen. So these are the testing you are going to do, and typically where will you see the hemolysis? Hemolysis, if you ask me, it's IgG only. I told you IgG is an excellent opsonizer. It's a very good opsonizer, so which means the macrophages are the ones that are predominantly going to kill this RBC. So it's going to be predominantly extravascular more than intravascular hemolysis, which means very commonly you are going to encounter the splenomegaly. Splenomegaly is very common in warm type. That is because of the prominent extravascular hemolysis. Similarly, you can get here in both this condition, it's intravascular more than extravascular because it's complement mediated. Both are actually, you can see it's both are complement mediated. So in complement mediated, usually intravascular will be more than extravascular hemolysis. That is due to formation of the membrane attack complex. Everyone knows that. Then if you see the peripheral smear, what will be the smear finding? Smear finding, I told you, in extravascular hemolysis, due to macrophage attack, the prominent thing will be formation of spherocytes. Spherocytes are very typical of an extravascular hemolysis, which I have discussed already. Similarly, here what you will see is, in intravascular hemolysis, very prominently you will see Role formation. Role formation and red cell agglutination in both cold types. Red cell agglutination. This is what you see. Role formation and red cell agglutination is what you are going to see. And spherocytes may be seen, but very much reduced. Spherocytes are very less in number. This is not a very important finding, but spherocytes are a major finding in warm type autoimmune anemia, whereas this Role formation and red cell agglutination is what is the major finding in case of a cold hemolytic anemias. So then if you see the clinical features generally tend to be acute and severe in this condition. Warm type generally tends to be acute and severe. Usually they will have fever, jaundice and splenomegaly. You can easily confuse with malaria and acute viral hepatitis and all. So they may have a fever, jaundice and splenomegaly or hepatosplenomegaly. Both are possible. But this is the common presentation, acute and severe. Whereas chronic hemolysis is a feature of cold. That's why you can remember cold means chronic. So chronic hemolysis is a feature of cold. Generally they tend to be less severe compared to that of warm type. More importantly, they will have anemia and hemolysis will be, anemia and hemolysis will be there. The hemolysis definitely will have history of cold exposure because these antibodies work only when there is an exposure to cold. Otherwise they don't work at all. So that is the reason why history of cold exposure will be there along with the hemolysis. And the patients will have acrocyanosis. What is the evidence of cold exposure if they ask you? Apart from history, if somebody asks you evidence of cold exposure, many patients may develop acrocyanosis. But in general, splenomegaly is very, very rare in a cold hemolytic anemia, autoimmune hemolytic anemia, because it's not a predominant extravascular hemolysis, it's a predominant intravascular hemolysis. So that's the reason why splenomegaly is not that prominent. Splenomegaly is rare. Usually you have anemia, hemolysis, history of cold exposure with acrocyanosis, with maybe normal spleen without any splenomegaly if they give, that generally goes towards a cold autoimmune hemolytic anemia. Then if you ask me about the treatment part, steroids are the mainstay. Steroids are the mainstay here. They work brilliantly because they reduce the production of IgG. Beautifully they work, steroids. But here there is no role for steroids. Steroids never work for cold types. There is no role for steroids here. At the same time, additionally you can try rituximab, plus or minus you can even try splenectomy, because spleen is the source of destruction. Here you can't try splenectomy because splenectomy again will be useless, but additionally you can try rituximab here also. But splenectomy again will not work, steroids. Maybe you can try rituximab, but the most important thing for cold types will be avoid cold exposure, because this antibody can cause hemolysis only after exposing to cold. So that is the reason this will be the main treatment here, avoid cold exposure. Rituximab is an additional option, but steroids and splenectomy will not work. But here steroid splenectomy works, rituximab again as usual it's a additional option, because the idea of giving rituximab is rituximab reduces the antibody production, any antibody. Even SLE use rituximab just to reduce the antibody titers. So any condition that produces high level antibodies, you can give rituximab because it reduces the B cell number. It's actually toxic to the B cells, and B cells are the ones that are going to produce antibodies later on by differentiating into plasma cells. So definitely it's going to be of much help, rituximab. So these are some of the differences between a warm, cold and your paroxysmal cold hemoglobinuria. First of all, if you want to know, the most important points are incidence, where warm is more common. Let me put in a different color. Recap, incidence wise, warm is going to be ruling the roost. Antibody wise, paroxysmal cold hemoglobinuria and warm type both are IgG, but whereas only thing that is IgM type is the cold agglutinin type. And complement activation is seen only in cold types, it's not seen in warm types. And again, antibody attachment is different, optimally at warm 37 degrees C for warm, and at less than 37 degrees C for cold agglutinin disease, and you have a biphasic type of antibody binding with paroxysmal cold hemoglobinuria. And antigens, I told you that anti-I and anti-small I and capital I is very important because that's multiple times asked question. And testing wise, you can see IgG plus or minus C3 in warm, only C3 in case of cold types, that is cold agglutinin disease and paroxysmal cold hemoglobinuria. Again, hemolysis typically extravascular in case of warm and intravascular in case of cold types, that is cold agglutinin as well as paroxysmal cold hemoglobinuria. And finally, in peripheral ischemia, spherocytes are the major finding in warm, as well as whereas the agglutination, Rowley formation, red cell agglutination and clumping is a feature of cold types. Treatment wise, splenomegaly is a feature of warm type only, so that is the reason why the steroid splenectomy and all works for warm types, but this doesn't work for cold types. Rituximab can be used in both, but the most important treatment for warm is steroids. Most important treatment for cold types is avoid cold exposure. That's all. So these are the major things that are very, very important. And most importantly, I didn't discuss about the causes. What will be the causes for warm type and what is the cause of cold type? So if you ask me about the cause of warm type, it can be idiopathic. It can be due to autoimmune disorders like SLE. Autoimmune disorders can well cause typically SLE. SLE is a classical example for this warm autoimmune hemolytic anemia. So SLE can cause, you can result in lymphoproliferative disorders, lymphomas like CLL, NHL, all these things are lymphoproliferative. Hodgkin doesn't cause, non-Hodgkin or CLL, all these things can cause, especially typically NHL, can cause this kind of warm type hemolytic anemias. Then a lot of drugs can cause warm hemolytic anemias, which I'll discuss later in the next section. Then you have a lot of infections that can cause warm hemolytic anemia like HIV and babesiosis. All these things are possible. So all these things can cause warm autoimmune hemolytic anemia. Cold agglutinin disease wise, if you ask me, cold agglutinin syndrome, many of the cases can be idiopathic as usual, cold agglutinin syndrome. Then you can get with lymphoproliferative disorders, typically happens in monoclonal lymphoproliferative disorders like plasma cell dyscrasias, Waldenstrom's macroglobulinemia. All these things can cause cold agglutinin syndrome, and similarly, a lot of infections can also cause. Typically, I told you two infections already. One is mycoplasma and second is EBV, that is infectious mononucleosis. So remember, usually lymphoproliferative disorders will be monoclonal. Lymphoproliferative disorders causing cold agglutinin syndrome will be monoclonal, whereas this infections causing this cold agglutinin will be polyclonal. So antibodies can be monoclonal or polyclonal. So infections causing this type of cold agglutinin disease will be having polyclonal antibodies, whereas this obviously this lymphoproliferative disorders causing cold agglutinin disease will be having monoclonal antibodies. So these are some of the cause of cold agglutinin disease. Paroxysmal cold hemoglobinuria is again idiopathic, can be seen in certain infections. Examples of infections that can cause PCH is Epstein-Barr virus, varicella zoster virus, and syphilis. Epstein-Barr virus, varicella zoster virus, and syphilis. So this is what is going to happen. See, these are some of the examples of each causes of paroxysmal cold hemoglobinuria, cold agglutinin disease, and warm autoimmune hemolytic anemia. So these are the differences which are very, very important to understand. We have constructed a table in the first place. Then if you ask me, there is something called a drug-induced hemolytic anemia. That's what you have to remember. So this is a very important topic for exams as well, drug-induced hemolytic anemia. So to understand what is drug-induced hemolytic anemia, we'll see this particular image. Before that, this is what we called as Donath-Landsteiner test. Donath-Landsteiner test. So what do you mean by Donath-Landsteiner test is, because this test is to prove the biphasic nature of the antibody, that Donath-Landsteiner antibody, biphasic nature of Donath-Landsteiner antibody. So you have to prove that. How will you prove? You can see this is the control serum. Where the control serum, you don't have hemolysis at all. There is absolutely no hemolysis in the control serum. But you can see the patient serum as well as the mixed serum. Mixed means they will have patient plus normal, both are mixed. So you can see in the patient serum as well as the mixed serum also contains the patient serum. That's why you can see if you incubate for 90 minutes at 0 degrees C, there is no hemolysis. No hemolysis. Clear? And if you incubate at 37 degrees C for 90 minutes again you don't see any hemolysis, isn't it? You don't see any hemolysis. But on the third area, where the RBs are incubated at 0 degrees C initially for 30 minutes, then they are rewarmed to 37 degrees C for 1 hour. Now you are getting hemolysis. This red color turbidity, this is what we call hemolysis. Now you are getting hemolysis, which means this is what is proving the biphasic nature of the Donath-Landsteiner antibody, and this testing is what we called as Donath-Landsteiner test. How will you do Donath-Landsteiner test? If they ask you initially incubate RBs at 0 degrees C, you won't see hemolysis. Incubate only at 37 degrees C, you won't get hemolysis. Incubate initially at 0, then rewarm to 37 degrees C and see, definitely there will be hemolysis. This proves the biphasic nature of the antibody. This is what we refer to as something called Donath-Landsteiner test. So coming back to drug-induced hemolytic anemia discussion, drug-induced hemolytic anemia can be divided into 3 components. So that's in all these 3 I have given an example. So 3 components I am going to divide. One, you can call it as these 2. The first 2 are drug dependent. Third one is called drug independent. Third one is this methyl dopa. Example is methyl dopa. In this condition, it is drug independent. So what are the models? The first one I'm going to discuss is, this is on the Hampton model. Hampton model. So what do you mean by Hampton model? In Hampton model, there will be drug and antibody. Drug and RBC membrane will be there. Drug will be bound to the RBC membrane, and antibodies will be formed against the drug and RBC membrane complex. The drug will be bound. Initial drug is also not an antigen. The RBC membrane is also not an antigen. But when they mix, they form an antigenic potential. They will develop an antigenic potential. That's what we call the hapten. So when the RBC mixes with that particular drug, and that will become antigen, new antigen now, and antibodies will be direct against that complex, the drug RBC membrane complex. This is what we call a hapten model. And typically it results in something called an extravascular hemolysis, and antibodies formed are IgG, which means it's going to be of warm type. Clear? It's going to be a warm type, and it's a typical extravascular hemolysis. And IgG means they can produce both complement activation as well as you're going to get phagocytosis. But prominently, you know very well that complement phagocytosis is the one that is going to cause this extravascular hemolysis, but complement activation may cause a little intravascular hemolysis, but anyway the most important thing is the extravascular here. And next thing is, if you ask about this mechanism, this is something called immune complex formation. Immune complex formation. In this condition, the drug does not directly bind to the RBC membrane. In this, what will happen is, initially you will form this is your drug, and this is the plasma protein. Any plasma protein, they bind with the plasma protein, and this becomes an antigen, and you will develop your antibodies against this drug plasma protein complex. And all these three things, the drug, the plasma protein and the antibody complex, all these three things will deposit on the RBC, and which will activate the complement. This will result in complement activation and hemolysis, which means this is typically of immune complex. The immune complex will contain the drug, plasma protein and antibody complex. All these things will come and deposit on the RBC, activating the complement, resulting in a autoimmune hemolytic anemia. So which means in this condition you will see typically intravascular hemolysis, then extravascular hemolysis, and the predominant thing that is activated is C3, and the antibody is actually IgM. IgM is going to activate the C3, and DCT will be positive in all the cases, I told you already. So it is predominantly IgM, and it's typically intravascular hemolysis by formation of pores. And the third one you have is something called your unknown mechanism. Third one, typically we don't know the mechanism. Here the problem thought to be due to unknown reason. The antibody is directly directed against the RBC due to some unknown components. We don't know what the components, but some antibodies are directed against the RBC itself. Usually you see this kind of things in very rarely, but typically it is going to result in extravascular hemolysis, which means the antibody will be IgG. And again, the main predominant thing is phagocytosis with a little bit of complement activation. That is the main reason why you get this third variety. So first is Hampton model, second is immune complex model, and third one is unknown idiopathic model. So if you ask me, is there any other drugs apart from penicillin? Yes. Apart from penicillin, you might get this kind of reaction with ampicillin. You can get with second and third generation cephalosporin. Then usually this is very rare to happen. This happens if you are sometimes when you are giving antibiotic in massive doses. Then this is possible to happen, but apart from that, this is very rare. Then about this one, the classic example of this immune complex mechanism is quinidine. Apart from quinidine, you have other drugs that can cause similar kind of mechanism in hemolysis. One is rifampicin, second is ribavirin, sulfa drugs, INH, probenecid, 5-fluorouracil, and melphalan. All these things are other examples, but very commonly asked in exam is the probenecid, rifampicin, and INH. So these are the common drugs that are asked in this group. This is an immune complex model, but more important is the quinidine. Quinidine is a classic example. Then third one, apart from methyl dopa, what are the other drugs? Apart from methyl dopa, you can get with procainamide. Methyl dopa is the classical example, procainamide. Then you can get with interferon alpha, you can get with L-dopa, you can get with cladribine and fludarabine, and you can get with certain NSAIDs also. So, but most important is the methyl dopa in this group. So that's what is very important. Remember, DCT will be positive in all these conditions. DCT will be positive in all these conditions. What will be the DCT positivity here? IgG. Here the DCT positive will be on C3. Here the DCT positive will be on IgG again. So this is the three differences. Remember, there are three models. One is Hampton model, second is immune complex model, third is unknown mechanism. Where Hampton model, the drug directly binds to the RBC membrane, that becomes antigen now, and for that against with the antibodies will be developed against the drug RBC membrane complex, so that they will go for extracellular hemolysis, splenomegaly, and all warm features you will have, because the antibody formed is IgG here. And whereas in immune complex model, the usual antibody is IgM. How it is formed is against the complex. That is what complex? That is a drug plasma protein complex, where the IgM antibody will bind with the drug plasma protein complex, which further deposits on the RBC membrane, activating the complement, causing predominantly complement-mediated lysis. That's why it is more intravascular in nature, and the DCT will show only C3 predominantly. And final type, unknown mechanism, where drug, whether it, how much it's important we don't know, but it is true formation of antibodies that are direct against the RBC itself. Where the drug comes here, we don't know. The drug may induce the formation of these kind of antibodies, but there is no complex as such. The antibody truly binds the RBC and destroys the RBC. Classic example for this is quinidine, we have discussed. And again, it is DCT positive. IgG will be the primary antibody, and it might and it's also going to result in something called a extravascular hemolysis. So these are some of the three classic mechanisms how you will get a drug-induced hemolytic anemia: Hampton, penicillin, immune complex quinidine, and finally unknown mechanism is methyl dopa, where it induces the true formation of antibodies against the red cell membrane itself. So now only one important thing again we have to tell is the red cell fragmentation syndrome. Red cell fragmentation. Red cell fragmentation is of two types. One is called microangiopathic hemolytic anemia, and second one you have something called a macroangiopathic hemolytic anemia. Whenever you think about a microangiopathic hemolytic anemia, the first one you have to think is about a HUS-TTP complex. Then it can happen with the DIC, disseminated intravascular coagulation. It can happen with the renovascular disorders, renal vascular disorders or renovascular hypertension. It can happen with preeclampsia and HELLP syndrome. It can happen with malignant hypertension. It can happen with vasculitis like PAN. It can happen with cyclosporin. It can happen with homograph rejection, graft rejection. All these things you might happen. But the most important in this group is the HUS-TTP and the DIC complex. Very, very important. Maybe malignant hypertension to an extent, and preeclampsia help, but most important is the HUS-TTP and DIC complex. Macroangiopathic, where here in microangiopathic hemolytic anemia, the problem is endothelial damage. Either there is some meshwork of platelets formed here, or the endothelium is very thick, which means either in this meshwork or in the thickened endothelium, this RBCs cannot pass through this RBCs cannot find a hard time passing through the small vessels, resulting in shearing and tearing of RBCs, resulting in the hemolysis. Typically, red cell fragmentations results in intravascular hemolysis most often. Macrovascular RBC, it's a rigid metallic structure, like you can result in valves, heart valves, especially the prosthetic heart valves. I'm not talking about natural valves, it's prosthetic heart valves. Then in moderate to severe aortic stenosis, and you might get in when the blood is passing through a dialysis circuit, or if the patient is having an AV malformation, or there is another entity called March hemoglobinuria. March hemoglobinuria because the RBCs are circulating the feet because of the march past or because of the strenuous exercise. RBCs that are traveling in the feet might get compressed repeatedly, and they may go for shear stress and mechanical stress and hemolysis. So that is the reason why it is called, again comes under red cell fragmentation syndrome. Usually the classical feature of this red cell fragmentation is the presence of cystiocytes in the peripheral smear. These are typically referred to as fragmented RBCs, and this is where you will get typically, this is a classic finding of this microangiopathic and macroangiopathic hemolytic anemia, where you don't see cystiocytes. If they ask you, answer is March. March, typically the smear will not contain cystiocytes. And the hemolysis, if you ask me in red cell fragmentation, as I already told you, it is typically intravascular, because fragmentation happens inside the vasculature itself. So typically it's going to produce a intravascular hemolysis. Remember, whenever you think about a macroangiopathic, heart valves, dialysis circuit, march hemoglobin. And one more condition I didn't tell you, forgot to tell you, is LVAD devices, like when they're passing through a ventricular assist device. That is also a rigid metallic structure. While passing through that, RBC may get damaged because it's a metallic structure, that's why. So these are the two important things, that is microangiopathic hemolytic anemia or less macroangiopathic. Microangiopathic is due to problem in the endothelium or the microvasculature itself. While passing through them, they cannot pass through. With great difficulty, when they go through, they get teared off on the sides and all, which may result in leaking of the contents and hemolysis. Macroangiopathic, it is due to a RBC passing through a rigid metallic structure causing shear stress on the RBC, causing hemolysis. Remember, both are intravascular, and almost all the red cell fragmentation syndrome, including micro and macroangiopathic, is going to result in cystiocytes in the peripheral smear, but except in march hemoglobinuria, where you might not have a cystiocyte in the peripheral smear. So these are some of the examples of immune hemolytic anemia and red cell fragmentation syndromes. With this, we can complete this hemolytic anemias itself as a whole. Then in the next section, we might be discussing on macrocytic anemias as well as aplastic anemia.